Today we will continue for the second part of how to approach or how to interpret chest X-ray in emergency and non-emergency examination. And by the way, we will revise some points that we discussed in the first lecture, and we will revise our checklist. Okay, are you with me now?
It's
Okay,
okay now.
we
It's
have
okay now.
3B. Okay, 3B, pneumothorax, pneumomediastinum, and pneumopericardium, and 3C, consolidation and cavitations, and the opacities, nodules, and masses, and fibrosis and emphysema. And also, we will start from here now, collapse, and we will go to the cardiac shadow, and 3B, behind the heart, below the diaphragm, and diaphragmatic lesions, and breast shadow. And finally, we will talk about midline to outside technique. It will include lines, mediastinum, hilum, hidden areas, and bony cage. As we see here, this is a chest X-ray. We have an opaque right hemisthorax with mediastinal shift, something like volume loss. And this is the key for the collapse. Collapse means opacity with volume loss. Also here, we have here basal opacity, and the diaphragmatic border doesn't appear, or what we call obscuring, or what we call silhouetting the right diaphragmatic border. We will discuss, before we discuss the collapse, we should revise some points in the normal chest X-ray. To differentiate between different types of collapse, we should know where is the cardiac border. This is the left cardiac border, and this is the right cardiac border, and this right diaphragmatic copula, left diaphragmatic copula, and chest wall, and you should see the hilum bifurcating in its position. If we need to know the right upper lobe collapse, it will occupy this upper lung zone. And in the lateral view, it will occupy this zone, and it will be bounded by the horizontal fissure inferiorly. While the right lower lung lobe, it will occupy the middle and lower lung zones. And in the lateral view, it will be behind the oblique fissure. While in the right middle lobe collapse, it will occupy this area. And in the lateral view, it will be bounded between the horizontal fissure and the oblique fissure infero-posterior. In the left lung, it will show for a little bit different pathology or different situation. We have here the left upper lung lobe collapse. It will cause opacity for the left whole hemisthorax, not like the right side. Why? Because the left upper lung lobe, it will include the lingular segment. We don't have here middle lung lobe. So the left upper lung lobe collapse, it will occupy the anterior part here from the lateral view, and it will occupy the whole, almost the whole left hemisphere. While the left lower lung lobe collapse, similar to the right lower lobe lung collapse, it will occupy the middle and lower lung zones, while in the lateral view, it will be behind the oblique fissure. So our key for the collapse is to see the borders of the heart and diaphragm especially, and to see the hilum, and to see if there is any volume loss or not. You will see here, this is triangular opacity. Here is the horizontal fissure. It should be here, but there is a volume loss, so it moved upwards or superior. This typical case of right upper lung lobe collapse. This one, this is a cardiac shadow, and this is left lower lung lobe collapse. You will see a different opacity, different from the heart. One of the most difficult points to differentiate between the left lower lung lobes and the cardiac shadow. I want you to see this one. This one is right upper lung lobe opacity, but this one is right upper lung lobe consolidation, pneumonia. Why it's not collapse? Because there is no volume loss. This is the horizontal fissure. Look for this image. The horizontal fissure will be displaced superiorly. So we have here volume loss equal right upper lung lobe collapse. Here we don't have any volume loss. we have an heterogeneous opacity in the right upper lung zones consistent with upper lung loop consolidation. Here, we have here basal opacity, and this basal opacity obscuring the right diaphragmatic copula. We don't have a clear demarcation for the right diaphragmatic copula, so this one is right lower loop collapse. I need you to concentrate also for the hilum. This is a normal hilum, while this one is the right hilum. It's not look. It doesn't look normally because this hilum is displaced inferiorly, and we don't have a clear bifurcation. And this one of the most important signs for any collapse. You should see the hilum similar and bifurcating. This one doesn't mean middle lung loop collapse. Why? Because the middle lung loop collapse will affect the right cardiac border. The right cardiac border will be obscured, while the right lower loop collapse, it will obscure the right diaphragmatic copula. Similar like this one. Here, you can identify the diaphragmatic copula, while medially, you couldn't identify. This one, another example for left lower loop collapse. This is a cardiac shadow. Look for the double density. Sometimes it will not be similar like this, but this one is straightforward, and we have also mediastinal shift. So we have something like volume loss here, and this diaphragmatic copula, this one is clear, while this one appears indistinct. So we have here left lower loop collapse. Also, I need you to see the lateral view for the same patient. We have here the dorsal spine. When we go downward, as we discussed in the first part of our lecture, when we go down, more down, the lung field should be more darker. While here, in this situation, we have an opacity here. So there is something wrong. It should be revised. In the AB or BA view, we will have here left lower loop collapse. Here, there is another opacity, right paracardiac opacity, while this one is different from that we discussed before. Why? Because the diaphragmatic copula appears more distinct. It is not obscured, and this opacity is hypodense, not like before. This one, a normal variant or a variant, what we call pericardial fat pad. There is an excess of fat in this area in some patients. So don't misdiagnose this one with right lower loop collapse. This one we will have here, this is not normal right cardiac border. There is something disturbed in this border. It's not like normal, and some ill definition in this BA view. Maybe something pathological. You should revise in this patient the lateral view. You will see here this shape and this shape between the oblique fissure posteriorly and the horizontal fissure. The horizontal fissure in the lateral view should pass this way, this line. But in this case, it is displaced inferiorly and posteriorly, forming what we called middle lung loop collapse. Sometimes this one can be confused with incested pleural effusion in the fissure, in the oblique fissure. But in this case, together with the BA and lateral view, it's straightforward for right middle loop collapse. This one classic case for left upper lung loop collapse. As we said before, the left upper lung loop collapse will cause an opaque hemisthorax, something like this, and sometimes sparing some lucency around the aortic knuckle, what we call Loft-Sichel sign. This is a typical case for left upper lung loop collapse. Also, this is another case of left upper lung loop collapse. Left upper lung loop collapse will cause an opacity for the left hemisthorax, sometimes sparing an area besides the aortic knuckle. There is, by the way, there is multiple nodular opacities in the right hemisphere, and also there is multiple opacities, nodular opacities in the left hemisphere. This one of the most important and critical signs for the loop collapse. Look for this one. This is straightforward as we discussed before. This is right upper lung loop collapse. I need you to concentrate for the inferior margin for the collapse. This one is smooth and concave, while this one, there is something convex, making convex border for the upper lung loop collapse. One of the most dangerous signs, what we call golden S sign. Golden S signs means that we have here a hilar mass, and this hilar mass causing obstruction, and secondly, we have right upper lung loop collapse. So how can we differentiate between the benign, what we call, and for me, I always differentiate between the benign and malignant collapse. We have different types of collapse, but let us discuss together how can we have a benign features like this one, while this one is the malignant features. This is a concave, smooth border. This is a benign collapse. But this one, we have here underlying mass, underlying hilar obstruction by a mass. So this one needs further investigations, contrast enhanced CT study or something like that. So we have here, this is a mass and this is collapsed lung. Another example for the golden S sign, look for this one. We have here right upper lung collapse, but the hilum here, it looks convex, not concave. So we have here golden S sign. Also we have here, this is a golden S sign. We have here hilar, huge hilar mass. And we have right upper lung loop collapse. Now we will shift for the cardiac pathology. For the cardiac pathology, I will not go in depth for the cardiac pathology in the chest X-ray because I am focusing more for the lung pathology. But we can revise some basics for the cardiac anatomy. For the BA view, in the right side, this is the right atrium. So the right cardiac border, it will be formed by the right atrium. Superiorly and posteriorly, we will have the left atrium. And we have here a small part of the left atrial appendage. This one in the third space, as we discussed in the first lecture. And we have the left ventricle. Left ventricle, this red one, it will form the left cardiac border. In the lateral view, the right ventricle, it will form the anterior part of the heart, while the left atrium, it will form posterior part of the heart. And I need you also to know that this is the carina. The carina should be less than 90 degrees. We have here, this is the right ventricle, and this is the left ventricle, and here is the left atrium, and we have here the trachea, and we have here the retrosternal opacity. Simply, how can we identify cardiac enlargement in the BA view? As we discussed in the first lecture, we can measure the cardiothoracic width and the width for the thorax, and we can divide this one by this one. Normally, it should be before 0.5 or before the half of the width of the thorax. We can measure also, there is another way to measure the cardiac width. We can go a line perpendicular to the trachea, central line, and we have here the most largest line here, and we can calculate this one and this one. So we will have the cardiac width, and we can divide this one by the thoracic width. We will discuss in brief right ventricular enlargement, left ventricular enlargement, mitral stenosis, and congestive heart failure, pericardial effusion, pulmonary hypertension. Look for this one, this classic form for the right ventricular enlargement. How can we identify? We have clearly, we have increased cardiothoracic ratio, and we have here the cardiac apex. It is uplifted and elevated above the diaphragm. forming acute cardiophrenic angle. Look for this one. This is what we call cardiophrenic angle. This one is an acute form. So we have here right ventricular enlargement, while the left ventricular enlargement increased cardiothoracic ratio, but the cardiac apex is directed or displaced downward and to the left side, and the cardiophrenic angle is obtuse or merging with the diaphragm. It's not acute. So we have here left ventricular enlargement. We have here a prominent pulmonary segment, as we discussed in the first part. This is the first rib, so this is the first space. First space, this consists from the aortic knuckle. Second space below the second rib, this one is the pulmonary segment, and this one in the third space, this one is the left atrial appendage. So we have here a prominent or dilated pulmonary segment in the second space. Look for the normal. This is the normal, and this is the abnormal pulmonary segment. This is a normal pulmonary segment, and this is abnormal. We have also what we call the mitralization of the heart. How can we identify mitral stenosis or mitralization of the heart? We can see the aortic knuckle is small, it's logic, and pulmonary conus enlarged, left atrial appendage prominent or enlarged, and left border of the left ventricle no change. Yeah, it will not be changed because the problem in the mitral valve, mitral stenosis, the left ventricle is away from this passage. Again, how can we identify dilated pulmonary arteries? This one is the left side dilated, and this is right side. It's dilated, but it maintains the bifurcation for the hilum. So it's not a hilar mass because this one is bifurcating and this one also bifurcating. So we have here a dilated pulmonary artery. It's straightforward with pulmonary hypertension. This is a classic form for what we call mitralization of the heart. Why? We have here the aortic knuckle. We couldn't identify where is the aortic knuckle exactly. And we have here large pulmonary segment, and we have here prominent atrial appendage, and we have also enlarged left atrium. How can we identify an enlarged left atrium? We have many signs to identify the enlargement of the left atrium, but we will concentrate here for these two signs. Widening of the carina. Look for the carina of the trachea. It is dilated or widened more than 90 degrees. It's about 120, something like this. And we have also double shadow for the left atrial enlargement. This is the left atrium, and this is the right cardiac border of the right atrium. We have double shadowing. And this double shadow indicates left atrial enlargement. So we have two signs here, widening of the carina and double shadow for the heart. And we don't have a clear signs for left ventricular enlargement. So we have here mitralization for the heart. Is that enough? It's not enough. We should also see the pulmonary vasculatures or the lung fields to exclude any pulmonary edema, especially in these cases. This is a normal pulmonary vasculatures. For a little bit, there is relatively distended upper lung loop vessels, but we don't have a clear signs of significant pulmonary edema. This one we have here enlarged cardiothoracic ratio, and this apex is directed downward. It looks like left ventricular enlargement. As we discussed before, any case of cardiac enlargement, we should comment on the lung fields. The lung field should be clear. The hilar vessels or the upper lung loop vessels should be attenuated or should be less distended than the left or right lower loop pulmonary vasculatures. Again, the pulmonary vasculatures in the lower lung zones should be distended or dilated more than the upper. This is a normal. And we have here normal cardiac width. Look for this one. This one is, we have here distended upper loop vasculatures, and this one of the starting signs or beginning to form pulmonary edema, distended upper lung loop vessels, and we have also here an interstitial lines here and here and here and here, perpendicular to the chest wall, what we call Kerley's B line. And by the way, we have here cardiac enlargement, so we have a signs of pulmonary edema, most likely cardiogenic. So we have here this Kerley's B line. For a little bit, we have here some alveolar shadows, or what we call ground glass. It is not clear like lung ABCs. And we have here a blunted costophrenic angles. So how can we identify pulmonary edema in a case of cardiac enlargement? First, descend upper loop vessels, Kerley's B lines. Sometimes we can see this ground glass veiling for the post-lung fields and obliterated costophrenic angles for minimal pleural effusion. Look for this one to identify easily the Kerley's B line. This is the lines that we discuss. Kerley's B lines is small horizontal lines perpendicular to the chest wall. And we have also here alveolar shadows. We don't have here a normal lung fields. So we have mixed here interstitial and alveolar. This one in the latest stages of pulmonary edema. Also, we have here blunted costophrenic angles, Kerley's B lines, and we have here some alveolar shadows, what we call bad wings appearance. Bad wings appearance. Bad wings appearance. It occurs with pulmonary edema. Look for this one. And we have here, by the way, there is a valve or prosthetic valve for the mitral valve. So there is a case of mitralization for the heart associated with pulmonary edema. Here, we have here Kerley's B line. Yes, you are right. We have some veiling for the lung fields. We have here Kerley's B lines, but I need you to compare this one with what we discussed before. We don't have any blunting for the costophrenic angles. And the most important, or the more important point, this cardiac shadow is a normal cardiothoracic ratio. We don't have any enlargement for the cardiac shadow. What does it mean? We have a pulmonary edema, but normal cardiac shadow. Yeah, what we call non-cardiogenic pulmonary edema. We have a list of different causes that may cause pulmonary edema, but different from cardiac disease. How can we differentiate? Simply look for the cardiac shadow, look for the costophrenic angles, look for the distended upper loop vessels. We will differentiate between. Here we have two images. On the right side, this is cardiogenic pulmonary edema, and on the left side, it's non-cardiogenic pulmonary edema. How can we differentiate? The vascular distribution, yeah, you are right. This one is descended upper loop vessels. It's not appear here. The cardiac size is one of the most easy way. This enlarged cardiac size, and this is a normal cardiac size. Distribution of the edema more centrally as we discussed before, bat wings appearance. While this one, more or less homogeneous, it can take the periphery of the lung, apex like base. It will not focus on the central zone of the chest. Also, we have here blunted costophrenic angles, so we have here mild pleural effusion, but we have clear costophrenic angles. So it's easy to differentiate between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Here we have classic enlarged cardiac shadow, but this one we discussed in the first lecture also, that we have here as stenciled borders for the heart, flask shape for the heart, and this is a classic case of pericardial effusion. We don't have any landmarks for specific chamber enlargement. Sometimes we couldn't differentiate exactly between the pericardial effusion and enlarged cardiac chambers. We have here some signs that we discussed also. We have Oreococcus sign. Oreococcus signs means in the lateral view, we have here an opacity between two hypodense lines. These hypodense lines contains fat, pericardial fat, and this is the pericardial effusion in between. So we need to check again our checklist. Our checklist contains pneumothorax, pleural effusion, pneumomediastinum, pneumopericardium, 3C, consolidation and cavitations together, and the opacity nodules and the masses together. And we have something reduce the lung inflation or reduce the lung fields fibrosis. And in the opposite side, we have emphysema, hyperinflation. We have collapse, second C, and we have cardiac shadow. And you should see together with the cardiac shadow if there is any signs of pulmonary edema or pulmonary hypertension or not. So we will shift now to the 3B, and before we shift to the 3B, I need to notify some things that maybe I'm hurry or I'm talking in a rapid way, but this one is recorded and you can see this lecture later on. 3B, behind the heart, below the diaphragm, and the breast shuttle. We will go to the behind the heart here. This one, we saw something like this before. This is a cardiac shadow. You should see here, there is something more dense here, overlapped for the cardiac shadow. This cardiac shadow is not homogeneous. This one is less dense and this one is more dense. So there is something wrong. This classic case of what we said before, left lower lung loop collapse, something like this. Also, we should have, as we discussed, we should concentrate what is behind the heart. It's not simply you can say this cardiac enlargement. No, you should see what is behind. Is there something behind or not? We have here something behind the heart. Something like mass-like lesion. It's speculated, ill-defined, something like this behind the heart, one of the hidden areas. Here, we said before that behind the heart, this is the first B, second B below the diaphragm. Look for this one, this is the diaphragmatic copula, and this is left side diaphragmatic copula, and we have here some lucency between the diaphragm and this shadow. This is a shadow for the liver. So we have here subphrenic gas for perforated viscous in the abdomen. Don't misdiagnose. This one is inside the bowel, but this lucency outside the bowel. This lucency is outside the bowel. And this one is a clear, it's between the diaphragmatic copula and the hepatic shadow. This is a classic case also for subphrenic gas or pneumoperitoneum, here and here. We are now shifting to, we are now still in the second B. Second B includes the behind the diaphragm and the diaphragmatic lesions. This one is RTA, and this RTA, we will go to the checklist, but I need to concentrate to this point. This left diaphragmatic copula. It looks abnormal. Yeah, it looks abnormal. It's not smooth, and it's serrated, or there is an irregularity in the left diaphragmatic copula. And yeah, you are right. It's elevated, markedly elevated. And we have also in the right side multiple rib fractures. And this one may be pulmonary contusion or something like this. And we have here mediastinal shift. For this diaphragmatic elevation, you should suspect there is something wrong in this diaphragm, maybe some diaphragmatic rupture. Yeah, you are right. This is CT for the same patient, and this is diaphragmatic rupture. one of the most important signs you can diagnose by chest X-ray, or you can suspect this one by chest X-ray. So we are now discussing behind the heart, below the diaphragm, and the third B, the breast. Look for this one. This is the left breast, and where is the right breast? There is a mastectomy or absent right breast shadow. And the third B, breast shadow. Someone may ask me, what is the importance to see the breast shadow in the chest X-ray? One of the most important part to see the breast. Sometimes it may be the clue for the case. Look for this one. This is a normal breast shadow, and we have here an absent right breast shadow. This one, there is a right mastectomy, and this one can answer why this right hemisthorax appears more lucent than this left hemisthorax. This one for the right mastectomy. This one, we have here multiple nodular opacities. Sorry for the bad quality for the chest X-ray, but this one we have multiple nodular opacities. Maybe infection, maybe metastatic, maybe. How can we differentiate, or what is the most important part here to narrow your differential diagnosis? This one here we have the right breast shadow, while the left side we don't have breast shadow. We have left side mastectomy for previous breast cancer, so we can put metastatic lesions before infection. But by the way, we don't have final diagnosis for this patient. Maybe infections, maybe metastatic, but breast shadow here, one of the most important part to see. This one also, we have here, this is a normal right hemisthorax, and this is a normal right breast shadow. We don't have here left breast shadow, but we have here another opacity overlying the left middle lung zone. And this one, by the history, this patient has a silicone implant instead of left, or in the place of left mastectomy. We will shift now to the checklist. As we discussed, we have 3B, behind the heart, below the diaphragm, and the breast shadow. And we will start now from the midline to outside technique. Midline includes the lines, one of the most important part. And by the way, the lines, we have different types, a lot of types of lines in the chest. We can make it a separate lecture, but we will focus now for one of the most important types or situations in emergency for the lines. You will see here, this intratracheal tube, and this intratracheal tube ended in the right main bronchus. This malposition for the intratracheal tube, and this tube causing an obstruction for the left loop bronchus, causing left lower loop collapse. Yeah, you are right, left lower loop, or left upper and lower loop collapse. The left hemisthorax totally collapsed, and we have a volume loss. Yeah, you are right, you have volume loss because of tracheal shift and also silhouetting the diaphragmatic copula. So we have left side lung loop collapse because of malposition for the intratracheal tube, for this one. This misplaced intratracheal tube. This is another example for misplaced intratracheal tube. This one going to the right bronchus. This left hemisthorax, non-aerated left upper and lower lung loops. This one is a normal tracheal position. How can we identify normal tracheal position? Look for the carina. This is a carina, bifurcation for the trachea. The distal end for the intratracheal tube should be between 3 and 5 centimeters above the carina. The standard says it's 5 centimeters above the carina, plus or minus 2 centimeters. 2 centimeters below, 2 centimeters above. This is a maximum, or this is average for the normal position for the intratracheal tube. This one is an nasogastric tube. Should be go downward to the stomach, but in this one we have a male position for the intratracheal tube, sorry, for the nasogastric tube. It passes through the trachea for the right lower lobe bronchus. It doesn't appear within its normal position. We have here a cardiac shadow, a large cardiac shadow, and we have here a pacemaker, and the pacemaker here we have two electrodes for the pacemaker, but actually we have here a fracture or interrupted one of the electrodes for the pacemaker, one of the most common complications for the pacemakers. Here, broken pacemaker wire. We have also here a pacemaker. The electrodes is intact going through, but we have a pneumothorax. We have here clear pneumothorax. Look for this one that we discussed in the first part. We have here splitting for the visceral pleura, and we have here jet black. We don't have any bronchivascular markings here, devoid of bronchivascular markings. So we have here a pneumothorax complicate as it is a complication for pacemaker application. Now we will shift to the mediastinum. Before we discuss the mediastinum, because this one I think one of the most crucial part in our lecture, we should identify, as we discussed before, this trachea and this right paratracheal strip should be clear. This aortic knuckle, we should see the aortic knuckle and the descending aorta. This one, this red line, this left cardiac border, and we have here the pulmonary artery, and we have here the right cardiac border, and we have here the azygoesophageal line. To be easy for you, look for the most important parts. Mediastinum widening means the mediastinum width greater than 6 centimeter on erect BA or 8 centimeter on supine ABPU. I need you to concentrate for this one because actually we have some missed cases. We saw it. It was not diagnosed in the beginning as a mediastinal mass. It was missed, but on the follow-up, we pick up this one and identify later on that we have a mediastinal mass. So mediastinal mass is one of the most important points to identify or to diagnose, to be diagnosed in the chest X-ray. We have a lot of differential diagnosis for the mediastinal masses. I will go rapidly. We have here the anterior or superior mediastinum. Simply, for me, I always remind myself by this one. We have 4T. What is a 4T? T-cell lymphoma or lymphoma, T-cell lymphoma, thyroid, thymus, teratoma, 4T, and we have aortic aneurysm. For the middle, we have lymphadenopathy, aortic aneurysm, pericardial cyst, and dilated esophagus, and Hayes hernia. For the posterior mediastinum, one of the most important masses in the posterior mediastinum, neurogenic masses, or the extension from the spinal masses, or extension from spinal pathology, like paraspinal abscess for spondylolischitis or something like this. One of the most important part today, how to differentiate between mediastinal and parenchymal masses. Unlike lung lesions, the mediastinal mass will not contain air bronchogram. So mediastinal mass, no air bronchogram. The margins with the lung will be obtuse. Yes, because the mediastinal mass arising from the mediastinum. It should be merging or obtuse angle with the mediastinum. We will not move with the respiration. It's pencil sharp borders, most likely pencil sharp borders. And we have the mediastinal mass always should have broad base towards the mediastinum. Look for this one, pulmonary mass, and this one, mediastinum. This pulmonary mass form an acute angle with the mediastinum, while this one form an obtuse angle for the mediastinum. Again, this pulmonary mass will form an acute angle with the lung mediastinum interface. This one. This interface between the lung and the mediastinum, we have here an acute angle. So this one has a pulmonary mass, while this one form obtuse angle with the lung and mediastinum interface. So this one is mediastinal mass. Simply, we have here an example. We have here a shadow forms an acute angle with the mediastinum. So this one, pulmonary mass, while this one form an obtuse angle with the mediastinum. So this one we have mediastinal mass. The second step to differentiate between the mediastinum and hilum. One of the basics in the chest X-ray, ask yourself first ask yourself, do you see the hilum or not? If you couldn't identify the hilum as we discussed before, hilar bifurcation, so this one is a hilar mass. If you identify the hilum clearly, so this one is away from the hilum, maybe anterior to the hilum, maybe posterior to the hilum. To be clear here, this X-ray, we have here something like this, dense shadow within the left hilum. Do you see the hilum bifurcating? No, I couldn't see the hilum bifurcating. So this is a hilar mass. This is a normal hilum, while this one is a hilar mass. Another example here. Do you see the hilum? Yes, I see the hilum. This is the hilum bifurcating. This is the vessels. But I have here a mass. Yeah, you have here a mass. You are right. But this mass is not arising from the hilum. Maybe anterior to the hilum, maybe posterior to the hilum. This mass, by the way, merging or obscuring the cardiac border. So it is anterior to the hilum. So this is a mediastinal mass, most likely anterior. In the lateral view, we have here, this is the mass. So it is anterior to the hilum. This is the hilum, and we have here anterior to the hilum, we have here a dense shadow. This one, clear pulmonary mass. Why it's pulmonary? Because it causes acute angle with the mediastinum, and the hilum appears clear. So it's not hilar and not mediastinal. This, please remind yourself by these three images. This is hilar mass. This is mediastinum mass because I see the hilum clearly within the mass. This is not mediastinum, not hilum. Not hilum because this is a hilum. Not mediastinum because it causes or it forms acute angle with the mediastinum. Hilar, mediastinal, pulmonary. For this example, we have here a mass forming an obtuse angle with the mediastinum, and we can see the hilum inside the mass. So this one is a mediastinum, not hilar, not pulmonary. This mediastinal mass obscuring the right cardiac border. So this one is anterior mediastinal mass, not hilar. It is anterior to the hilum. Why it's not hilum? Because we can see the hilar mass inside the mass. Why it is not pulmonary? Because it forms an obtuse angle with the mediastinum. This is classic superior mediastinal mass encasing the trachea. We have here also left side pleural effusion. This lobulated outline for superior mediastinal mass and occupying also the right paratracheal region. As we said before, this one should be clear. This is superior mediastinal mass and confirmed as lymphoma. This one is superior mediastinal mass also, yeah, you are right, and we have tracheal shift to the right side. But the important sign here, this superior tracheal shadow continuous with the neck, most likely goiter with retrosternal extension. Look for this one, this is a different one. Here we have here the trachea. We don't have here any shadows. So it most likely mediastinal and separable from the neck. while this one, it's most likely coming from the neck. So it most likely goiter with retrosternal extension. This is another example for retrosternal extension for the goiter, continuous with the neck. And look for the aortic knuckle, it's clear. So it's not posterior mediastinum. We will discuss after some slides here. How can we differentiate between anterior and posterior mediastinal mass? Simply, if the mediastinal mass obscuring the cardiac border, it is anterior mediastinum. If it is obscuring one of the posterior mediastinal structures, such as aortic shadow or descending aortic shadow, it is posterior mediastinal mass. This mass is mediastinal mass and obscuring the right cardiac border, so this one is obscuring knuckle. Where is the aortic knuckle here? Yeah, you are right. This is a mediastinal mass, but obscuring the aortic knuckle, so this one is posterior mediastinal mass. This one, a large mass here, and this large mass continuous or merging with the mediastinum and extending above the clavicle. Any shadow or any mediastinal shadow above the clavicle may be neck mass or posterior mediastinal mass. In this case, it's posterior mediastinal mass. Why it's not anterior mediastinum? Because the anterior mediastinum stops here at the level of the clavicle. If the mass is continuous above the clavicle, so it is posterior mediastinal mass, what we call cervicothoracic sign. This is another example here. We have a mediastinal mass extending above the right clavicle, so it's posterior mediastinal mass. Simply or similarly, we have here shadow continuous below the diaphragm. So it's posterior mediastinal mass, what we call the abdominothoracic signs. So we have two different signs also to differentiate between posterior and anterior mediastinum. Cervicothoracic signs, any mass above the clavicle, posterior mediastinum, and abdominothoracic sign, any mass below the diaphragm, it's posterior mediastinum. Look for this one. This one is a mediastinal shadow obscuring the cardiac border, left cardiac border, but the aortic shadow is clear. So this one is anterior mediastinum. This anterior mediastinal mass most likely or confirmed as cymoma. While this one, look for this one, this is a mass. And this is the aortic shadow. This is anterior mediastinal mass. By the way, this one was missed at the beginning. This is the mediastinal shadow and obscuring the left cardiac border, while the aortic shadow is preserved. So we have here anterior mediastinal mass, and this one is confirmed as cymoma. This one, we have here a mediastinal mass. The cardiac border is clear. You can see the cardiac border is clear, while the aortic shadow or the descending aorta is less distinct. It appears less distinct. So this one most likely posterior mediastinal shadow. The aortic line or the descending aortic line, it's not appear clear like example before. This one is clear, but this one it's not clear. So this one is a posterior mediastinal mass. Here also posterior mediastinal masses, and this one, by the way, post-trabeculae sickle cell anemia, and this one is extramedullary hematopoiesis. Look for the ribs, look for the bone, it's abnormal bone. This is another example for sickle cell anemia and extramedullary hematopoiesis. This one of the important signs or important locations for the mediastinal masses. Look for this cardiac shadow, and this is a shadow behind the heart with air fluid level. It's classic form for sliding head hernia. This one, air fluid level or gas fluid level, sliding head hernia. This is another example for the sliding head hernia. If you have here a shadow behind the heart, ask for the lateral. This one will appear like this, retrocardiac shadow for sliding head hernia. This is another example for sliding head hernia. This shadow. This one you can see here gas fluid level, but this one is different from before because it looks like tubular structure, large tubular structure with gas fluid level. It's achalasia for the esophagus. Now I need you to increase your differential diagnosis for the hilar masses. Bilateral hilar lymphadenopathy, you can see it in sarcoidosis, lymphoma, sometimes in TB, histoplasmosis. Unilateral hilar lymphadenopathy, most likely lymphoma or carcinoma, sometimes in TB and histoplasmosis. Look for this one. This is an hilar opacity. And this hilar opacity, you couldn't identify the hilum as the right side. It's not mediastinal, it's not pulmonary. So we have here a hilar mass for further assessment. Here, do you have here hilar mass? No, it's not hilar because you can see the pulmonary vasculature. So we have here a mass overlying the hilum. So it's mediastinal mass, it's not hilum. What does it called? This is called hilum overlay sign. What does it mean, hilum overlay sign? Hilum overlay sign, if you have mass like this, as we discussed before, if you can see the hilum, so it is not a hilar mass. It's hilum overlay sign. It is overlapping over the hilum, maybe anterior mediastinum, maybe posterior mediastinum. Same like we discussed before. This what we call hilum overlay sign. So any mass here, you should see, ask yourself, do you see the hilum? Yes, I'm seeing the hilum. I see the hilum clearly. So it is not hilar mass. Maybe mediastinum, maybe pulmonary. This one is a mediastinal mass because it causes obscure angle or obtuse angle with the mediastinum, and we have a broad base with the mediastinum. In the lateral view, you can see this one here. So this one is anterior to the hilum. Here, another example. You can see the hilum. Yes, I see the hilum. So it is a mediastinal mass. Do you see the cardiac border? Yes, I am seeing. I see the right cardiac border clearly. So it is not anterior mediastinum. It is posterior mediastinum. Don't be confused with the pulmonary hypertension. Pulmonary hypertension will cause also enlargement for the hilar shadow, but it will maintain the bifurcation for the hilum. One of the most important points in our checklist from the midline, let us revise again what is the midline to outside technique. Midline, starting from the lines, then mediastinum, then hilum, then hidden areas. All hidden areas we discussed before, starting from the lung ABCs, we have 4 hidden areas. Should be checked. You should check these hidden areas before you say this chest X-ray is normal. Hidden areas includes the lung ABCs, if there is any pneumothorax, any masses, or any nodules. The hilum, the left hilum is for a little bit higher than the right hilum. The retrocardiac area, and below the diaphragm. These are the 4 hidden areas. One of the most important points in reading chest X-ray. Now we will shift for the bony cage. We have here the chest is clear. We will go down all checklist clear, but we have here fracture clavicle. You should see the clavicle, the ribs, rib by rib, and you should see the scapula and the humerus. And in the lateral view, you should see the sternum. Here, we have here 3 pneumo, no 3 pneumo, no pneumothorax, no pneumomediastinum. We will go to the old checklist, but we have here fracture in the left humeral neck. Bony cage, one of the most important point in our checklist, especially in our hospital. This one, chest X-ray, lateral view, you should also see the sternum. It's clear. Manubrium sterni and sternal body, clear. The vertebral body, no wedging, but we have here sclerotic vertebral body in the dorsal spine, maybe metastatic, maybe something like this. It needs further assessment. For this one, this is the reps, this sclerotic rep. So we have here an abnormality. We have here this rep, first, second, third, fourth, fifth. This is the left fifth rep. We can identify this rep if we can make numbers from inferior to superior like this. This first 1, 2, 3, 4, 5. So this one is a fifth rep. So we can identify this one from above or from below. Here another examples for multiple rib fractures. It's a flail chest. Also we have here one of most difficult points in interpreting chest X-ray. We have a diffuse increased bone density in the bony cage. This is consistent with extensive sclerotic bone metastasis, maybe for breast or maybe for prostate. I think this one is a male patient, maybe prostate. Look for this one. Can we revise our checklist? Yeah, we can revise our checklist. Do you have pneumothorax? No, I don't have pneumothorax. Do you have pneumomediastinum? No pneumomediastinum. Pneumopericardium? We don't have any pneumopericardium. Consolidation and cavitations? We don't have. Nodules or masses? We don't have. Fibrosis? Reticulation, something like this? No. Emphysema? No. The diaphragmatic border is clear and maintaining its contour. And if you count this rep, 1, 2, 3, 4, 5, 6, it's not hyperinflated. So we don't have any fibrosis. Do we have any collapse? No, the hilum is okay. And we don't have any volume loss. The cardiac border is normal. So 3C, collapse, consolidation, collapse, cardiac border type. We will now shift to the 3B. 3B, behind the heart, it's clear. Below the diaphragm, it's clear. Diaphragmatic lesions, it's clear. Breast shadow, it's clear. From midline, any lines? No lines. Mediastinum, clear. No mediastinum, no paratracheal mass, no something like this. We don't have any hilar masses. Hidden areas, hilum. Sorry, hilum. Apex hilum, behind the heart and below the diaphragm, we don't have. Bony cage, we don't have any abnormality except this one. Is a foreign body inside the right lower loop bronchus, inhaled foreign body or inhaled needle, something like this. We have also here, after intubation, something like this. We can see teeth impacted in the right lower loop bronchus. And by the way, we have here pneumothorax and partial collapse for the right lung loops. Some special cases, I will go rapidly in this one. If you see hemisthorax, like this one, right hemisthorax, opaque hemisthorax, right side or left side, we have a differential diagnosis. You can remind yourself, if the mediastinum pushed away from the ossified side, maybe pleural effusion, large lung mass, diaphragmatic hernia. If the mediastinum pulled toward the ossified side, total lung collapse, pneumonectomy, or pulmonary hypoplasia or agenesis. If the mediastinum remains central in the position, maybe consolidation, pleural, chest wall, mass, or combination of pathologies. For example, this mediastinum is away from the opaque hemisthorax, while this one, the mediastinum is central from the opaque hemisthorax. So we have here a differential diagnosis. If it's if the mediastinum shifted away, we have this differential diagnosis. If it is central, we have this one. if we have the mediastinum shifted towards the opaque side, we have this one, total lung collapse, pneumonectomy, pulmonary hypoplasia, or agenesis. The opposite side, if we have translucent or opaque hemothorax, we should first exclude any technical causes. Then we should look for the pulmonary vasculatures, if it is normal or reduced. If it is reduced, we have two differential diagnoses, maybe lung emphysema or pulmonary embolism. If we have normal pulmonary vasculature, so this one is away from the pulmonary pathology, we have maybe chest wall or pleural causes. Pleural causes may be pneumothorax or maybe pleural effusion, and you can or you misdiagnose that this one is the opaque hemothorax, but actually the pathology in the left side, the pleural effusion. Something like this. We can go to the image to be more clear. This one, a technical cause for the right hemisthorax. This one is lucent, more translucent than this one, because this one is not centralized. So the patient should be fully centralized. This one we have here, left hemisthorax, more translucent because of massive pneumothorax. Look for this one. This is a lung tissue, this collapsed lung, and this is a massive pneumothorax. Is it tension pneumothorax? Yeah, there is for a little bit tension pneumothorax. Why? Because this diaphragmatic copula is flattened more than the right side. So we have some sort of tension pneumothorax. This one, you can see here, translucent right hemisthorax. If you should exclude first any technical causes, so the patient is centralized well. But we have here a translucent right hemisthorax. Second point, you should go to the pulmonary vasculatures, almost same. So maybe pleural cause, maybe chest wall cause. This one, a chest wall cause, these pectoralis muscles, but this one, these pectoralis muscles are not present, what we call the Poland syndrome. It's a congenital anomaly. Here we can see this is for a little bit translucent more than this right hemisthorax. Is it technical? No, it's not technical. The trachea is centralized between the two clavicles. Look for the pulmonary vasculatures. You will see here the pulmonary vasculatures will be attenuated more than this one. So we have two differential diagnoses here, maybe pulmonary embolism, maybe pulmonary emphysema. And in this case, by the way, we have an obstructed mass, confirmed later on by a mass obstructing the left loop bronchus, and there is emphysematous changes left hemisphere. This one also here, translucent left hemisthorax, but the breast shadow can identify why this one is translucent, because this one is a normal breast shadow. We don't have here the left breast shadow. So as we discussed before, breast shadow is one of the most important points that we need to identify in our checklist. Also, we have here this one of the most important one of the most important film in our session. This an opaque hemisthorax, and you can see this one in RTA or casualty or something like this. You can identify or you can suspect if there is pulmonary pleural effusion on the left side or not. You can ask for to do the patient in erect position. You will see the pleural effusion clearly rising to the axil. This is the picture for the pleural effusion in the supine film. This one in the erect film. Also, we have here translucent right hemisthorax. This for massive pneumothorax, and this is a collapsed lung. This is another example for translucent left hemisthorax, but the translucent hemisthorax extending or crossing the midline, in this case consistent with congenital lobar emphysema. This also, here, the pulmonary vasculature is attenuated as compared to this one, and this is the cause for translucent left hemisthorax, and this proved case for pulmonary embolism. We have around 15 minutes, something like this, for the quiz cases. I think we have 9 or 10 quiz cases. If we have any volunteer to participate for this quiz case, it's very simple and very easy to finish our lecture and to revise our checklist point by point. If anyone wants to share, just raise his hand, and I think Rimas can help us in this issue. If anyone of the participants needs to share us in these quiz cases, this one we need to revise checklist, and the checklist will be beside you in the slide. Go point by point if it's present or not. It's very easy and very simple, and I think we will take around 15 minutes, something like this, to finish these quiz cases. Rimas.
Yes, doctor. If someone can raise the hand, then I will unmute the mic.
Okay. I'm ready. If anyone wants to participate to apply what we discussed in the 2 lectures.
السلام عليكم.
وعليكم السلام ورحمة الله.
مساء الخير يا دكتور محمد.
مساء النور دكتور علي، ازي حضرتك، عامل ايه؟
حياك الله. Good evening to you. Good evening to all. Thank you for this informative lecture.
Thank you.
Actually, يعني again and again, it is showing the importance of radiological test and study. From simple X-ray, we can find a lot of information. Even you can start by knowing the patient gender, patient cardiac probable age, cardiac status, respiratory system status, of course, even bone health, a lot of information. Also, thank you focusing and concentrating on the importance of the lateral view, which is most of the time missed by us, and which is we need to be familiar with that, with the lateral view and how to interpret it. Before we go to quiz, because I think this quiz, doctor, if you can excuse me, if we can make a separate lecture for it, for that, if it will be like interaction, and
Okay.
the decision will be yours. But my question before we will go to quiz, what's the because it's a challenge for the most of the doctors, either in the ER situation or in the inpatient. Sometimes of the positioning of the patient, difficult to do departmental AB or BA good view or good. So what is your advice if there is any difficulty in that, and the X-ray can help sitting or semi-sitting? What is the precaution that can be also done, or it is depend on the of course it is depend on the patient condition, but what is your advice regard this point? Thank you, doctor.
Thank
Yes,
you
doctor.
so much.
I think this session is going to end. I sent the new link now to all of you. Already I sent the link. Please log into the new link.
We will go to the new link. Thank you.
Thank you. Bismillah ar-Rahman ar-Rahim. Thank you so much for this important question, really. First, thank you for joining us in this lecture. Hopefully, this lecture will be so beneficial for all the attendants. To return to your question, one of the most important question here, because we have a lot of emergencies in our hospital. For the ER cases, for example, if we have a translucent hemisthorax and we have normal pulmonary vasculature, so maybe there is a pleural disease or chest wall disease, as we discussed before. So we are suspecting a pneumothorax, something like this. And you couldn't identify the pneumothorax. What is the solution for this one? If the translucent part in the right side, we can do left side lateral position. Left side lateral position, we will elevate the right hemisthorax to be above, to be superiorly, and we can clearly identify the pneumothorax, and this position can replace the erect position. In this situation, if the patient couldn't make an erect X-ray, we can make right or left side lateral view. On the opposite side, if we are suspecting pleural effusion or something like this, we can make it sitting. Yeah, we can ask the patient to sit, or we can help the patient to have a sitting position, and we can do it. We can do this one in our department. Make the patient in the sitting position, and we can make or we can move the tube and the cassette in or in a specific situation that we can identify, or we can simulate an erect position, but it's not a standing position for the patient. The patient is in the sitting position. So according to the situation of the patient, we can do it right or left lateral position. This one we can do it in the ER. It's very simple. We can use it by the portable X-ray to identify small pneumothorax or something like this. And in case if we have something like pleural effusion, or we need to do erect, but we couldn't have a standing position for the patient, we can ask the patient, or we can help the patient to have a sitting position, and we can move the tube to have something like erect position. Is that clear?
دكتور محمد السلام عليكم.
السلام ورحمة الله وبركاته. دكتور حسين ازي حضرتك؟
Really we are enjoyed with this very nice lecture and informative. My question also, like Dr. Ali, if the CT scan is available and it will give the information, and it can be much better than a plain X-ray, especially in this situation if the patient have multiple trauma and fracture ribs and needs. Why you repeat the investigation twice? We'll do plain X-ray, and after that we'll do CT scan. We didn't do CT scan from the start, because the information I will get from the CT scan not only on the ribs or like this, or not on the lung tissue also, because sometimes there is sedation, lung contusion, sometimes a hemorrhage inside.
Excuse me.
Scan.
Excuse me, Dr. Hussein. Good evening for you. Yes, you are right. When I ask this question, I ask when the patient difficult to shift him to the radiology department at all. You want to minimize the patient movement either in ER or in ICU or in patient area. So you want to minimize the patient movement, and if the patient can move to the radiology department, so it's okay if there is any trauma, or to do CT scan or non-trauma cases. But I mean, like what Dr. Muhammad mentioned, the lateral, you call it lateral. It is like the lateral decubitus, Dr. Muhammad, or
something like this. Both of you are right, correct. If the patient is stable and can move to our department, we can do it for him, CT for the chest, even for the abdomen. It's very simple to identify any subtle abnormality. We are talking about if the patient is unstable, and in the ER unstable, sometimes the patient will remain unstable for half an hour, something like this, till be stabilized. In this period, we can do chest X-ray, AB. We can do left or right lateral decubitus X-ray, and we can make semi-sitting position, some positions that may help us to identify the abnormality, especially in case of pleural effusion or pneumothorax or something like this. Sometimes the patient is unstable and we have tension pneumothorax and needs just intercostal tube to be more stabilized, then shift to the CT. This, I think, we faced many cases like this before.
Okay, thank you, Dr. Muhammad. Actually, it is informative lecture, and alhamdulillah, hopefully it will be, hopefully it's recorded, and anyone can go back to it at any time to see it once or to divide it to 2, 3, 4 parts to get more benefit. If we have time, and we can start with the quiz cases. Depend on you, Dr. Muhammad. You are the speaker, and you can,
as you like. If you are
because you are the most one who is exhausted now.
No, at all. I am not exhausted, but I need to share or to participate.
Okay, I will start with you, Dr. Muhammad.
Okay, okay, let's.
Dr. Habib has a question, sir.
Yeah. Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Okay.
Dr. Talat, very nice presentation, mashallah.
Thank you.
Yes, I was expecting something about barium swallow. To be very straightforward, going to my question, a lot of esophageal pathologies can be diagnosed on barium swallow. So, do you have any plan to throw some light on barium swallow later on, or secondly, I think this is not done in our hospital. Any plan to have some doing barium swallow in near future in our hospital, and presentation on that?
We have barium swallow in our department. It's very easy and very simple, and we have a lot of cases of barium swallow in our department. It's very easy to be done, and we have all facilities to do this exam. We can do it at different ages, no problem, and you're welcome at any time.
Thank you very much.
Yeah.
Thank you.
Welcome.
No more questions, sir.
No more questions?
No more.
Can we go to the quiz cases? Okay. Right. We start first. I think Dr. Ali is here with us.
Yes.
Dr. Ali, yeah.
Yes.
This is a chest X-ray BA view for the patient, and we have here the checklist. You can go one by one till you get the abnormality.
Okay. Let's start with 3B. Pneumothorax or pleural effusion. I'm not, but in the right side,
yeah,
there is flattening of the diaphragm.
Okay.
And the costophrenic angle is not
clear. Yeah, you are right.
Not clear.
Yeah.
Okay. This is regard the pleural effusion. So the possibility in the pleural effusion, the right side.
Okay.
You want me to go with the one by one, Doctor?
No. That's enough. I need to ask you. Do you see the bronchivascular markings reaching the periphery for the lung?
No. In the left side, no.
In the right side, no. So
sorry, in the right side. There is no.
This one is jet black. So we have
more lucent.
More lucent and jet black. You couldn't identify any bronchivascular markings.
Exactly.
So, yeah. So you have here a gas lucidity, gas air. And I agree totally with you. This one is a fluid obliterating the costophrenic angle. This one is not the cardiac, sorry, this one is not the right diaphragmatic copula. This one is fluid, air fluid level. This is hydropneumothorax, and this is a collapsed lung tissue.
Right lung.
Okay, yeah. But there is another important sign in this chest X-ray. As we discussed before, any pneumothorax or any pleural effusion or something like this, we should look for the mediastinum. Is that mediastinum central or not?
No, it is shifted to the left side.
To the left side, you are right. So we have here tension hydropneumothorax, not simply hydropneumothorax. This one is an urgent situation.
Mm-hmm.
Okay, that's good. Okay. Well done. Thank you so much.
Thank you, Doctor.
Thank you. Any volunteer? It's an easy chest X-ray. Anyone wants to participate? It's very easy. Go to the checklist one by one. Do you have here any pneumothorax?
Yes, Dr. Habib is here, sir.
Okay.
Dr. Talat, although the chest X-ray is the graveyard of radiology, but I think I can pick the diagnosis. There is gas under the right side of the diaphragm, most likely perforated viscous.
Yes, you are right. We don't have any pneumothorax, no pneumomediastinum, no pneumopericardium. We don't have any consolidation cavitations. We have clear lung fields. We don't have any collapse. The cardiac shadow is normal. Anything behind the heart? No. Below the diaphragm, we have bilateral gas lucency. We have pneumoperitoneum or subdiaphragmatic gas lucency. Okay, well done. Thank you, Dr. Habib.
Thank you.
Shift to this one. This another example, or this another chest X-ray. Very easy also to identify. Any volunteer? Anyone wants to share?
Yes, Doctor. Again, Dr. Habib.
Okay, Dr. Habib, go on.
Just wait a minute. Let me see the picture
Okay.
again. I think most likely there is left-sided hilar mass, mostly hilar mass.
This hilum is branching
Yes.
like this one.
I think
Yes.
I was
Yeah.
sleeping at that time when you were discussed.
Okay, no problem. We don't have pneumothorax, pneumomediastinum, no pneumopericardium. Do we have any consolidated patches? No. Cavitations? No. Do we have any nodules or masses? No.
No.
But we have something like reticulations or network of opacities. Network of opacities. And we have also the hemithorax is reduced in volume. This one is classic form for interstitial lung fibrosis or fibrotic patches or fibrotic opacities in the chest. This one needs high resolution CT chest. Okay, let us shift for this one. It's very easy.
Dr. Ali is
Yeah.
here.
Okay.
Dr. Muhammad, there is some nodularity
Yeah.
on the right side, like a nodular shadow.
Yeah, you are right. Well done. Yes, you are right. We have here this point reduce. We have here in the right upper lung zone, we have a nodular opacity. By the way, this one confirmed bronchogenic carcinoma. So you should go point by point. Don't forget any point of this point. Well done, Dr. Ali. Thank you so much. This one, I think it's very easy.
Sorry, Dr. Muhammad. Can you come again? We did not. I did not hear you.
Yeah, you are right. Well done. We have here nodular opacity in the right upper lung zone. And this one, by the way, confirmed later on by the CT and CT guide biopsy as bronchogenic carcinoma. So it's well done to identify this abnormality. And if you go, as we discussed before, point by point in our checklist, it will be simply to identify. Thank you so much. Okay, this one, I think it's very easy, and I will take a hand for this one. We have here right lung loop opacity, and we have air bronchogram inside. This air bronchogram confirmed that this one is a pulmonary lesion, and this air bronchogram confirming that we have a patent central airway, and this one is consistent with consolidated patch, pneumonic patch. I think this one is easy to identify. Okay, this one also, I think it's easy, and we have an examples before. This is a case of right side pneumothorax, and this is a collapsed lung tissue, and all of this jet black, and we have for a little bit flattened right diaphragmatic copula, and this one going with right side pneumothorax. Any volunteer to go to this chest X-ray? We need someone from the surgery department, because it is one of the important points for the surgery department. Really. No one? Let's take a hand.
Dr. Ali is here, sir.
Yeah, okay.
Left pneumothorax, Dr. Muhammad.
You are right. Well done. Yes, you are right.
I get it because you asked for surgery. I thought
it's a first
there's
point.
something surgical.
Yeah,
something surgical, not medical.
Yeah, you are right. This is collapsed lung, and this is the visceral pleural crossing the rib, as we discussed in the first part or first session. And this is jet black. This is a pneumothorax. It doesn't look like this one. Look for these bronchoplastic markings reaching the periphery, while this one is jet black. Sometimes there is surgical emphysema in the chest wall. Maybe this one help you to concentrate more if there is a pneumothorax or not. Okay, this one I think one of our difficult chest X-rays. So I will take a hand in this one. If you go here to the pneumothorax, and yeah, you don't have any pneumothorax. Pleural effusion, because we are talking for the pleural diseases, one of the most important type or subtype for the pleural effusion, what we call subpulmonic effusion. And this is subpulmonic effusion. If you go to this left diaphragmatic copula, this one is elevated more than the right side. This is one of the abnormalities. Why? Because always the right diaphragmatic copula is higher than the left side, because this one below the right diaphragmatic copula there is a lever elevating the right diaphragmatic copula. This one is abnormal. If you look for the gastric air bubble, there is more than 1 centimeter distance between the left diaphragmatic copula and the gastric air bubble. So you should have here this something abnormal. Exactly, this one is not the left diaphragmatic copula. This is the pleural effusion between the left lung and the left diaphragmatic copula. So we have here subpulmonic pleural effusion. Again, the right diaphragmatic copula should be higher than the left side. If you have any abnormality regarding the level of the left diaphragmatic copula, look for the gastric air bubble. If there is a distance more than 1 centimeter, so we have here subpulmonic pleural effusion. How can we confirm this one? We said this one in the first lecture. We should have a lateral decubitus X-ray. You can see clearly the pleural effusion. This one was recorded in the first lecture. We need here volunteer, because this one.
Dr. Muhammad, excuse me, for the new fusion, the costophrenic is preserved.
Yeah, you are right. Yeah, you are right.
So
it's not freely pleural effusion. It is subpulmonic. It is insinuated between the lung and the diaphragm. It will maintain the costophrenic angle.
So it will be preserved.
And for this example, this one is left side. Okay. So ask the patient to have left lateral bending position. The effusion will move from here to be here. between the chest wall and the lung.
And the idea from and the idea is the right diaphragm is lower than the left diaphragm in this X-ray.
Yes.
Okay.
It's difficult to identify on the right side, but it's more easier to identify in the left side.
Okay, thank you, Doctor.
Okay. We need the volunteer here. This one is very simple. I think we have 1 or 2 X-rays in our quiz cases. We are around to finish, but we need to have a volunteer here. It's very easy. If there is no one here, do we have any pneumothorax? No. Do we have any?
Yes, Dr. Wael is here.
Yeah, Dr. Wael, go on. My friend, my brother.
Assalamu alaikum.
Wa alaikum assalam wa barakatuh.
Thank you, Dr. Muhammad, for this informative lecture.
Thank you.
There is retrocardiac triangular opacity.
Yeah, you're right.
Collapsed left lower loop.
Yeah, you are right. Exactly. Well done. We have here triangular opacity and obscuring part of the left diaphragmatic copula. This one is clearly identified, but this one is not identified. And this is a normal cardiac shadow. So we have here double shadowing with a straight border. And if you concentrate more, you will see the hilum. There is a posty or diminished hilar shadow. So we have something like left lower loop collapse, and this one makes this typical picture. Thank you, Dr. Wael. I think this one is similar to what we discussed before. We have here jet black, and we have here hydro pneumothorax, but it is not tension hydropneumothorax because we don't have any mass effect, no mediastinal shift, no diaphragmatic displayed. This one, I think we discussed this one, or we have a similar case. This mal-placed intracheal tube. The intracheal tube is positioned in the right bronchus, so totally occluding the left bronchus. One of the emergencies that we see at any time. Mal-positioned intracheal tube. We need one from the surgical department because this one is an emergency and very easy to identify. I think this may be may we have 1 or 2 slides more. Anyone from any department? Internal medicine, family medicine, chest. We need any volunteer. This one of the 3
Dr. Muhammad. Doctor, excuse me. Could you please choose any one of the audience, or?
I don't want to choose really.
Because even okay, let me to try. There is hyperinflated, first of all, hyperinflated both lung, or I can say that this patient has maybe COPD, chronic obstructive lung disease.
Can we go through our checklist? Do you see any pneumothorax?
No.
No. Do you see any pneumomediastinum?
Pneumomediastinum? No.
Look for this one, for this streaky lucences. Is that normal? It's not normal.
No, but no. The trachea, or what is it?
This is the trachea. Look for this one. This is the trachea. This is the trachea. But these lines, look for these lines. Do you see these lines? This line is parallel to the trachea, but it's not trachea. Trachea, this one is trachea from here to here. There is a widening for the mediastinum, and we have lucences inside the mediastinum. And by the way, here we have a surgical emphysema in this part of supraclavicular region. Any surgical emphysema you pick up, you should search for pneumothorax, pneumomediastinum. Exclude these 2 points. Pneumothorax, pneumomediastinum. We have here surgical emphysema. Look for the pneumomediastinum. We don't have any pneumomediastinum. Look for the, sorry, we don't have any pneumothorax. Look for the pneumomediastinum. Yeah, we have pneumomediastinum. And even we have here pneumopericardium, but ignore this one. We have concentrate for the mediastinum. We have mediastinum widening. This one is not normal, and we have pneumomediastinum. Please, Dr. Ali, can you stay with us for this X-ray? Do you hear me?
Yes, yeah, doctor. Yes.
Okay. This one, can you please help me to identify what is the abnormality?
There is bilateral flattening in the diagram, hyperinflated.
Yeah, you are right. You are right. This is a typical case for hyperinflation or pulmonary emphysema. How can we identify this one? Normally, the 7th rep intersect the diaphragmatic copula at its midpoint. We discussed this one in the first part of our lecture.
Can you put a pointer, Dr. Mohammed?
This one, this is the first rep, this 2nd rep, 3rd rep, 4th rep, 5th rep, 6th rep, 7 reps. 7 rep should be intersect here in the midpoint, but it intersect the diaphragmatic copula more lateral. So this diaphragmatic copula is downward displaced, and as you said, there is a flattening for the diaphragmatic copula, and in the lateral view there is a widening of the retrosternal shadow, lucency. This lucency should be lesser or should be smaller than this one. So we have 3 signs for pulmonary emphysema. Hyperinflated lung fields by the reps and the flattened diaphragmatic copula. And we have also exaggerated or widened retrosternal lucency. This is a typical case of pulmonary emphysema. Thank you so much.
Thank you, doctor.
Thank you. This one, I think we have 2 slides. I will go ahead for this very strange chest X-ray. We have here something like an opacity going from the hilum downward to the right diaphragmatic copula. This looks like scimitar syndrome. This abnormality in the pulmonary venous drainage. Sometimes we see this opacity and we couldn't identify what is this, maybe pulmonary. This is classic form for scimitar, and this another syndrome. We have here the gastric air bubbles on the right side and the heart inverted to be here on the right side, and we have here some bronchiectatic changes or tubular opacities. This triad situs inversus with bronchiectasis, this Cartagena syndrome. I think now we are finished. We finished our lecture. Let us revise our checklist. We have 3B, pneumothorax with the pleural diseases, pleural effusion, pneumomediastinum, pneumopericardium, 3C for lung and cardiac pathology, consolidation cavitations, opacities including nodules and masses, fibrosis and emphysema. So we have the first C, consolidation, the second C, collapse, the third C, cardiac shadow, and you should look for the lung fields to see if there is any pulmonary edema or not. 3B, behind the heart or retrocardiac, if there is any mass, if there is any collapse, if there is any sliding head hernia or something like this. Below the diaphragm and diaphragmatic lesions. Breast shadow sometimes will be the clue for diagnosis. Midline to outside technique starting from the lines and foreign bodies. Don't forget any foreign bodies, and the history will help you. mediastinum, and 2H hilum and hidden areas. We have 4 hidden areas: apex, hilum, retrocardiac, and subdiaphragmatic. All of these hidden areas we discussed before in our checklist, but for the second revision. And the bone occasions, you should see the ribs, clavicle, scapula, humerus, vertebrae, sternum. Thank you so much. If there is any questions, I'm ready. If there is any questions from the participants? Okay, thank you so much, and thank you for joining me in this lecture. And I will be happy if you join me again in any of our lectures in our educational activities of Najran Armed Forces Hospital. Thank you so much. Thank you.